Welcome back to Family Health Today. A prostatectomy is a surgical procedure used to remove all or part of the prostate gland. Until recently, surgeries like this one came with many unwanted long-term side effects and sometimes long, difficult recovery periods. Now, robot-assisted surgery is changing that. And joining us to discuss the Vinci Surgical System and its role in providing a better outcome to surgical patients is Dr. Tony Woodruff from Northwest Medical Center in Springdale. Welcome to the show, Dr. Woodruff. Thanks for being here with us today.
Thank you.
Now tell us, what is your role in fighting cancer, and how did you come to practicing using the Vinci robots?
Well, I trained as a urology resident in New Orleans, and during that training, urologists learned to do lots of different things with the genitourinary system. That's namely the kidneys, the ureters, the bladder, and the prostate, as well as the male and female reproductive organs to some extent, more male than female. During that training, we do a lot of cancer training, cancer of the bladder, prostate, kidneys, and so forth. So during that training, I became very interested in specializing in treatment of those particular cancers. During that time also, I just happened to be lucky enough that people in the United States started integrating robotic technique on top of already being used laparoscopic technique to treat some of these cancers. And so as that came up and as that went forward, I became involved as a trainee, and then eventually on to fellowship to train for that, and then came back to Northwest Arkansas to practice urologic oncology.
Very great. Now, you are actually the director over at Northwest, is that correct?
I'm the director of robotic-assisted surgery, correct.
Okay, and
yes.
how did Northwest decide we want to start using this robotic system?
Well, that all came along before I got here, actually, but they had, I believe the story, if I don't want to get it wrong, but that there was a donor who had some issues with his prostate, and then gave a sum of money to the hospital to purchase the robot. None of the hospitals in the area had it at that time, and I believe this was in late 2006. They went ahead and purchased the robot, got the robot, started incorporating it in some of their care plans with both GYN and urology, and then I came along not long after that and started using it more and became the director of robotic surgery.
Very neat. Dr. Woodruff, tell me, how does the Da Vinci robot system actually work?
Okay. You make small incisions. I make small incisions on the patient's abdomen. I insert trocars through those incisions, and then hook up a surgical cart that is the robot itself to those instruments. I then break scrub, go over to a console, which is a TV monitor screen that converts the image into a 3D image. It has handles, controls, and several foot pedals, so that I'm working with both hands and several foot pedals and toggle switches and a whole control panel that I then control the robot from, so that the robot has no control over anything. Every move that's made is completely controlled by the surgeon, me. And in this case, I have two hands, but I have four instruments I can work with, a combination of my hands and feet. And it's a vast oversimplification, but some people equate it to playing a video game. And so coming up in the Nintendo era certainly benefited some of us younger surgeons in that way.
Well, that is just amazing. And why do you think that patients will benefit from the robotic surgeries?
Well, urologic oncology has come really a long way in the past 15 years. First implementing laparoscopic or minimally invasive surgical techniques, and then in the early part of this century, they came along with robotic technique, and we incorporated that. The reason I think patients benefit is that we can provide the same oncologic surgical principles and superimpose those into a paradigm in which we are operating from a minimally invasive platform. That platform allows for patients to have specifically less blood loss, less surgical incision and scarring, and a much quicker recovery back to their normal activity.
That is awesome. Who is not a candidate for this type of robotic surgery? Are there some patients that you cannot use the robots with, and some that you have to do the old-fashioned traditional method of surgery?
Really, in 2010, anybody who's a candidate for the traditional radical prostatectomy is a candidate for robotic prostatectomy in expert hands. Now, there are some caveats. Some people are simply not candidates for surgery. Some people are not candidates for treating their prostate cancer with surgery. But those candidates, those patients who are candidates for treating their cancer with surgery and for the traditional surgery are certainly candidates for robotic surgery as well.
I see. For those patients that aren't candidates for surgeries, what other options are there for them? if they have prostate cancer?
Sure, there are a lot of options. There are options namely of radiation, and there are different ways to deliver that, both externally delivered, external beam radiation, and implanting seeds or brachytherapy. There's also cryotherapy or freezing of the prostate. And then there are also adjunctive ways of treating it in addition to surgery, like hormonal manipulation. They've come out with in the last year, some very interesting findings for hormone-resistant prostate cancer in the way of prostate vaccines. Also exists prostate chemotherapy if it should come to that down the road.
So lots of options, very good. And is surgery the last resort? Do you always go to radiation or chemotherapy first, or do you say some patients, they're just too far along, they need to have the surgery right away?
Well, prostate cancer is a very complex disease. It's very misunderstood in the general public. Generally speaking, most organ-confined prostate cancer is amenable to surgery. Roughly 80 to 85% of American men that treat their organ-confined cancer choose to do it surgically. So generally speaking, surgery is the first line, followed by potentially salvaging a failure with radiation or hormones. Some men choose, who are maybe not surgical candidates or who just simply choose not to have surgery, do start with another modality. Generally, once you've had one of those other modalities, you don't then progress to surgery.
So what are some of the side effects after you have this surgery with the Da Vinci robot? What are the most common side effects that you see?
Well, because of the prostate's location in the body, it is very near several organs that are vital to function. And so because of that, any treatment for prostate cancer can affect things like the bowels, the bladder, incontinence, and potency. Because of that, robotic surgery for prostate cancer is just like open surgery in that it can affect continence, it can affect potency, and it obviously slows people down in their everyday life until they recover from the surgery. And so I would say incontinence and potency are the two big concerns that all prostate cancer patients share and want to preserve. And hopefully through robotic surgery, if they get, if they are candidates for certain things that have to do, this is kind of somewhat of a complex issue, if they're candidates for nerve sparing and things like that, which a lot of people are, then we oftentimes can keep that potency, and almost always we have good continence outcomes after surgery.
And would you say the incidence of those side effects and outcomes are less using the robotic surgery versus the traditional old-fashioned surgery?
I would tell you that I have science to, I don't have science to support that. The only studies that have been done, which have not been done in a head-to-head fashion of conventional surgery versus robotic surgery, show that the outcomes are about equivalent with the continence and the potency. And I think that the most important thing that matters when you're choosing whether you're going to have robotic surgery versus conventional open surgery is the experience of the surgeon. If the surgeon is a surgeon that's a high-volume surgeon who's done a lot of open surgery, then his outcomes, that surgeon's outcomes, are probably going to be better using the more traditional technique. If that surgeon is a high-volume surgeon doing robotic technique surgery, then the outcomes are probably going to be better using the robotic technique.
I see. Dr. Woodruff, this surgical, robotic surgical system was first created in the military, correct?
Yes.
How did it make its way into the operating rooms
well,
here?
I think that some of this might be somewhat hearsay, but from what I understand, the military had originally developed this as an idea of having stateside or at least remote surgeons operate on soldiers in the front. And while it's my understanding that that technology actually does exist, there's somewhat of a translational loss, because if the surgeon is away and operating and there's a problem, the surgeon can't be there. And so the military largely abandoned this specific technology and after putting millions of dollars into the development, and then ended up selling it to an American company, Intuitive, which bought the equipment and then took it to market and spread it to the general public, and now that's where we are today.
Ended up for good cause either way, huh?
Right.
All right, so now it's not just used for urological cancers, but also gynecological problems as well. Is that correct?
Correct.
And is it used usually as the first resort, as in urological cancers? You said usually that's the first line. Is that the same in gynecological cancers? Or I know that's not really your arena. But
again, I think that to answer the question more generally speaking, the things that we use the robot for in this community are prostate diseases, kidney diseases, bladder diseases, pelvic floor diseases and female pelvic floor dysfunction, and also benign and malignant female reproductive organ removal, hysterectomy, for both benign and malignant disease. The robot can also be used for other things as well. There are applications to cardiac surgery, head and neck surgery. Those things have not been adopted in this area
Sure.
and are, quite frankly, not as popular nationwide.
Have you used both the robotic surgical technique and the non-robotic?
Yes.
Which do you like better?
Well, I coming up in training before the robot was available, I originally learned how to do this procedure in the open technique, which is a very good technique. And then we begun doing them laparoscopically without the robot. In other words, using the small incisions without the robot. So I learned to do it that way. Then when the robot came out, we learned to apply the robotic technique. I use the robotic technique because I think it implies a few advantages over the laparoscopic technique, and namely the wrist instrument allows for more degrees of freedom, more degrees of movement, and I believe you can get into spaces a little bit more efficiently than you could without it.
And better recovery, like you mentioned earlier. Tell us, before we finish here, all-around support system that you guys provide at Northwest. Tell us about that.
Well, I think that prostate cancer is a disease that impacts not only the patient who has it, but also oftentimes their spouse, their significant other, their friends and family. And so because of this, I think it's an important disease state to be able to discuss with other people who have gone before you, so to speak. So we started together with the Arkansas Prostate Cancer Foundation, what we call a peer network group, which is essentially a support group of men and their families who have been affected by the diagnosis of prostate cancer, so that they can then, once they get the diagnosis, they can go to that group. They can also call the Arkansas Prostate Cancer Foundation and be mentored. And it's a group of people that meets once a month, and they are there to support people who've just gotten the diagnosis or ongoing treatment or just for ongoing support.
All right, very good. Well, excellent information. Thank you so much, Dr. Woodruff. We appreciate you being here with us today.
Yes, ma'am. Thank you so much for having me.
Stay tuned. Family Health Today will be back in just a moment.